Good morning, everybody. Welcome to MSU and Sparrow Pediatric Grand Rounds. I will also like to extend a warm welcome to our colleagues in Flint and Grand Rapids. Before we get started, we have a couple of announcements. Today at Subspecialty Rounds, Drs. Verk and Omshide will do a journal club. Please join us next week when Dr. Carney will present pediatric ingestions. I am now going to invite Dr. English to introduce this morning's speaker.
Good morning. Welcome to Grand Rounds. It's my pleasure this morning to introduce our visiting professor, Dr. Neelkamal Soares. Dr. Soares is a graduate of his MBBS degree from Bombay. Neil, I'm doing this by memory, so if I get it wrong, correct me. Then he trained in pediatrics both in Bombay and then in Chicago at the University of Illinois. After his pediatric training, trained in developmental behavioral pediatrics at the University of Maryland. From there, he took a faculty position at the State University of New York, I think in Stony Brook. He was at the University of Kentucky. He had a faculty position at UCLA and was also in Pennsylvania at Temple most recently before being recruited to Kalamazoo to Western Michigan, the home of Stryker School of Medicine. He's published well in developmental behavioral pediatrics with more than 30 peer-reviewed publications, and I've had the opportunity to meet and work with him as a colleague and collaborator. He has been very gracious in working together with faculty here from MSU as we have been brainstorming about how to build a telehealth program in the Upper Peninsula for children with autism and their families, and also to address some broader pediatric behavioral health issues. As I think everyone knows, we really Neil has had quite a bit of experience in using telehealth. He's been a great help and advisor to us. He's worked with Dr. Turner and colleagues in the Michigan LIND program, and so it's really a pleasure to welcome him here today to talk to us about telehealth and autism spectrum disorder. Neil, thank you.
Thank you, Dr. English, and thank you, Dr. Turner. Both of them have been instrumental in my very wonderful transition to Michigan, hitting the ground running with some exciting programs. This just disclosures, no financial conflicts. This is not construed to be medical or legal advice. And the last bullet point is particularly pertinent. This field and technology is changing so fast, as are the regulations. You know, what is true today, especially with some of the numbers, may be vastly different tomorrow. So this is current as of this month. We'll hope to get through some basics of telehealth, and really this topic is an intersection of two large topics, so I'll try and be concise. And telehealth by itself, telehealth in autism spectrum disorder, and then some practical points about operationalizing a program, and more importantly, autism spectrum disorder, ASD, cannot be managed or addressed just by the medical profession, and so we'll talk about interdisciplinary strategies. Just, as Dr. English pointed out, my personal journey. So it started like a lot of clinicians. I was a clinician taking care of patients in a clinic. I was in rural Kentucky and having a wonderful time with patients, seeing kids from a very large geographic swath. And then I got a faculty position at the University of Kentucky, but that was 100 miles away, and a lot of my poor patients couldn't travel. And so the question was, do I drive to them or do they drive to me? And certainly I continued to drive to them for almost a year. That's a 200-mile round trip that I used to do, every week. Then I spaced it every 2 weeks, and till I got sideswiped by a semi in 8 inches of snow on I-75, I was happy doing it. And then I I need to do something that'll keep me sane and them sane. So I worked with I got an AAP catch grant. My first grant was from the AAP. It was a catch grant. We started telehealth with some rural clinics, and then we expanded it to 3 different hospitals across eastern and southeastern Kentucky. And I continued that for a few years. I got recruited to be fellowship director at UCLA, and you'd say, well, Los Angeles is not a rural area, you don't need telehealth. Oh yes, you do, because I could actually drive faster 100 miles in Kentucky than 8 miles in Los Angeles. So it took me an hour and 15 minutes to go 4.2 miles from Santa Monica to UCLA. And there was no accident, so that's LA. So then I started doing telehealth with the, as they call it, the valleys. And it's a substantial hike for people in the San Fernando Valley to come down. And I started working with a pediatrician's office there to do telehealth for some of his patients. When I came to central Pennsylvania, I began to not only do telehealth clinically like I was, but I took a more administrative role. And so I ran telehealth programs, I established programs. And now, as Dr. English pointed out, I've been trying to be helpful in sort of brainstorming how telehealth can be used in the Upper Peninsula. I'll use as much as possible the term telehealth out of respect for our interdisciplinary colleagues. This is not just about medicine, and it's broader than just practicing medicine. It's also education and training. And so I've always in my presentations preferred to use telehealth. If you see the word telemedicine in a slide, it's probably referring to a publication or somebody describing their program as telemedicine. One of the sort of subsets of that, teleconsultation, is something you do, we'll see on the next slide, without the patient present. So it's consultation, but it's like without the patient there. So it's two providers talking. What you all are familiar with, oh, I'm going to do a phone consult, but when you add a video component or an interactive component, or you share data, then that really becomes a teleconsultation. One of the things with that is without the patient present, you generally cannot bill for it. You don't really have a relationship with the patient, so there's no real malpractice or patient responsibility issues. It lies with the requesting provider. So if a PCP contacts me and we have a video chat without the patient there, then it's incumbent on the PCP to do what they need to do on that end. I don't have to throw in a note. It generally works when there's a visual or verbal component. If you're just talking about a result of a lab or somebody wants your opinion on something, you can do that by phone. But if there's really a dynamic involved that you have to get a large amount of information and have a conversation, really knowing and seeing the person helps. It's also logistically slightly more difficult, but it can be done. The other place it's being increasingly used, the ACGME has realized that residency programs have residents in a variety of locations, and sometimes the supervisor in a different location. They used to make it that you could not supervise by distance, and they do allow some resident supervision through telehealth. I know that our colleagues at Pine Rest in Grand Rapids, the psychiatrist is supervising multiple child psychiatry fellows and residents through telehealth and then going in as needed. Some of you are familiar with Project ECHO. It's got a lot of buzz. It started out of New Mexico, mainly for COPD in adults. And basically that's primary care provider training and support from specialists. They provide them with clinical management tools, do topic discussions, case discussions. It really expanded around rural New Mexico. But then it got picked up. It became very popular. The AAP has signed on to be what's called a super hub, where AAP wants subspecialists to be available to this program and create this community. It's international now. There are a lot of countries which are signing on to be part of Project ECHO. And it's to the point where the government decided to do some further digging into it. And so a law was passed in 2016, which said the Department of Health and Human Services must study this effects of this model, particularly around chronic disease and pediatric health, because as you guys know, there's a shortage of specialists, and also there's an issue related to geographical access. So we won't do too much about teleconsultation for the rest of this talk, but I just wanted you to know that it exists. And an example in autism spectrum disorder is in my colleagues at the Thompson Center in Missouri are using a Project ECHO model with the primary care providers. They do case-based and topic discussions around autism. Another thing that can be done, and I did this pretty successfully, is you can do it for training programs. So the one in in Missouri is for practicing providers. But I feel that there's a strong use of teleconsultation and case discussion with training programs, residency programs, fellowships. So when I was in Kentucky, I would do consultations, not with the patient present again, we're talking about that aspect, with the general pediatricians, the residency program at WVU. And I currently, for the last 5 years, have been doing biweekly consultation and discussions with my colleagues in India. That's working very well. We've presented on it internationally. We've published on it, where they have a fellowship program in Mumbai, and I'm actually faculty on their fellowship training program, and we do the curriculum together through guiding the fellows, not just in discussions, but I've also mentored them on research, which has been accepted at international conferences. So there are many ways to mentor, and I think this is a very exciting way to do it, because learners and mentors can be in the same space at the same time. Telehealth is important because it's all about access, right? Location, location, location. Clinicians don't tend to go to areas where they feel isolated. Patients don't travel to areas that they perceive as too far, many of them. So then they find ways around that, and it disrupts the medical home model, particularly in adults. And if you put people in outreach, that's great. You're reaching the patients like I used to do in Kentucky. But that's 2 hours on the road for me each way that my bosses would go, and who's seeing patients in those 2 hours? Or, I'm sitting in a car, or puts me at risk for being sideswiped, things like that. So, physical outreach is fantastic, but it has its limitations and it wears people down. With individuals with disabilities, particularly ASD, this is particularly important because access is a huge problem. It's not just the primary care providers, but specialists. In autism, you need a village. And so you've got speech therapists, board certified behavior analysts. A lot of people need to be involved, not just in the community practicing, but also in the school systems. And the schools are suffering from a lack of specialists also, psychologists, behavior specialists. And so what happens is they're supposed to deliver an intervention. If you use a proxy person, the classic fidelity or the robustness of the intervention is slightly impaired. You can't report outcomes that I did it exactly the way the manual says, because the manual says must have a licensed clinical psychologist, and you're delivering it perhaps with a trainee because you don't have a psychologist. So it gets interesting around outcomes. And it's not always possible for people to travel. If a speech therapist is going from one school to another, he or she is traveling most of the day and doing very little sort of direct consultation. And the numbers are increasing, as you guys know. So this is a problem that continues to be compounded. And perhaps telehealth is one of the many solutions. The cart that you see there is something my friends in Alaska, in Anchorage, have used. They were one of the first people to use telehealth. It goes back, real telehealth goes back to actually Logan Airport and Mass General in the 1950s. They would have a communication line between the airport and the hospital for some medical situations. And that was the first quote-unquote telehealth encounter. The military, as you know, early adopter because they're all around the world. They're very robust in telehealth adoption. And most of the early things, including this cart cost at that time probably $35,000 to $40,000. And it had everything with it, a little screen, it had a camera, it had a stethoscope, otoscopes, the works. But it was very cumbersome. This thing is very heavy. I've actually stood in its presence, and it's heavy to move around. It cannot negotiate corners very well. And it required its own dedicated high-speed lines, which 30 years ago was very hard to do. And in those days, there were no laws around reimbursement, but somebody had to start. And now you've got this. You've got, desktop solutions, mobile solutions. You've got kiosk solutions. You've got every single piece of equipment from a dermoscope to ophthalmoscope, otoscope, stethoscope, you name it, EKGs, anything can be done through teleconferencing. And it's really the mobile devices which have taken off. Right now, about 90% of all US adults have a cell phone and 77% have a smartphone. It's 220% increase over 4 years. I mean, the most rapidly adopted technology, and combined with the explosion in the hardware, you have reduction in the cost, obviously, because of competition, and you have more blanketing of wireless networks, as you can see with the map. And this is a little dated map, but apart from a few mountainous and desert areas, the US is mostly blanketed with Wi-Fi and broadband, and both the FCC as well as the educational, the Department of Ed and all are heavily investing in schools, community locations to get broadband technology. So, some terms as we go along you have to be aware of. Asynchronous is something that doesn't happen in real time. So if I take a picture of a rash and I send it off and the dermatologist sees it a couple of hours later, that's asynchronous, also called store and forward. If I am video conferencing somebody real time, then that's synchronous. Remote monitoring is something maybe your diabetes patients would do. They use their glucometer, they collect their blood sugars, they upload it, or they send it in, or they call it in, or some of the Bluetooth glucometers will send it directly to the web portal, and then you can look at it. And that would be remote monitoring. We use this with scales for people with chronic heart failure to check their weights, blood pressure, pulse ox, you name it. And then mHealth is where your mobile devices come in, apps and trackers and sensors that collect data. And then you can do it for self-monitoring, but you could also share it with your clinician for them to enter the data. So there's different terms. They all fall under this umbrella of telehealth, but it's important to define them because reimbursement really is different for each type of telehealth delivery. Speaking of license, 15 states have a only telemedicine license, and now when I use the word telemedicine, this is because this is just for physicians. We'll talk about other providers in a second. But most of them require you get a full license, whether you intend to only do telehealth or not. The good news is that more and more states are doing what is called a interstate compact. And for anyone who's familiar with nursing, nurses can get a single license that covers 24 states. So if they happen to travel between Maryland, Virginia, DC, Pennsylvania on locum jobs or shift jobs, whatever, they don't have to get individual licenses in each state. So it's fabulous, but not so much for physicians. There's still interstate compact activity going on. The good news is it's growing rapidly. It was a year ago, 14 states had signed on, now it's 20. So that's pretty good. Michigan has introduced legislation. It hasn't yet passed. So hopefully if a Michigan provider wants to do telehealth in Ohio, they can have an arrangement where Ohio can look at Michigan's licensure and maybe expedite Ohio licensure and take a lot of information. So you, instead of filling out X number of forms and do everything else, it might be streamlined. The feds have been ahead of this because you need only one license in one state and you can practice in any Indian Health Service, any VA, any Department of Defense. You don't have to go and get it in each state. The laggards, if you will, have been Alabama, Georgia, and Texas, which actually have been more restrictive in terms of licensure and say, yeah, you can do telehealth, but then you're going to have to see them. And it's odd if you live 120 miles away and you're so happy to see somebody from telehealth and you go, I want to make my follow-up there. Yeah, come drive 120 miles. So there are some states which still do that. And part of the issue is the states are very concerned about, keeping a monitor on abuse and physician practice. But this number has actually gone down. It used to be much worse. Other specialties, not so lucky because they're still around defining telehealth. In the federal world, there are 28 different definitions of telehealth. It's absurd. So depending on which agency you're talking to, the definition is different. Audiologists, as far as 2014, that was the last data I had, only 17 states actually defined telehealth, but haven't come up with any policies around, is the licensure different? Psychology, only 11 have defined it, but in general, psychologists have to not only get licensed in each state, they have to take an exam in many cases. So count yourselves lucky, some of you, who don't have to take an exam if after you graduate, apart from your boards or whatever, if you go to each state and actually take an exam just to get licensed. Behavior analysts, it's tricky. Some states actually recognize them as needing a license to practice and some don't. So the rule of thumb is where the patient is your rule. So if you are here in Michigan, and let's say you got all your license and everything, the patient's in Ohio, you're bound by Ohio rules because that's where the patient is. Regarding speech and OT and PT, it's a little different. Michigan, for example, will cover speech and audiology through the school-based program. So it's a little different if you want to do it in the hospital where you're asking for reimbursement. So you really need somebody who's on top of this to guide you if you're starting a program, what the regulations are, who all is on your team, and what do you need to do. In Michigan, generally speaking, a lot of medical providers are covered as long as they're licensed, registered, and enrolled, and also psychologists and social workers. But a caveat for them is they have to bill slightly differently through mental health and certain codes. And so they have to be cognizant of that. For the medical codes, it's pretty familiar codes to the in-person, except you have to add a little modifier. So your biller downstairs or wherever has to be familiar with what these two letters are you are adding. Because if they don't understand it's a telehealth encounter, then it becomes problematic because the insurance company will look at the data and go, is this a telehealth or not? Because there's some things that cannot be done in telehealth or some things done by proxy. So the reimbursement, apart from Connecticut and Rhode Island, every state, and this is also better. Over the years, this used to be 35, 40, 42, 44, now it's 48. They have, now the key word is some form of reimbursement. There's no rule which says it had to be 100%. Only 23 states and DC say, if you get $100 to do it in person, you'll get $100 by telehealth. Some places go, oh, we'll cover you, but they don't state explicitly that it'll be apples for apples. Again, remember we talked about asynchronous, synchronous. Most of these rules, the 48, are for the live, the synchronous. Only 6 do it for asynchronous. So you have a problem if you want to get a peds dermatologist to look at your images. Sure, you can do it, but you may be one of those 44 states which go, sorry, we're not paying for that. Same thing when it comes to remote monitoring. You could have diabetics going, oh, this is wonderful, my doctor can see my blood sugars, but if you're one of those states, the 40 states which don't cover it, you don't get reimbursed. So it's very state to state dependent. And again, this could change. These have been changing. So these could increase. Generally, they don't go down. I've not seen any programs which withdraw, Medicaid programs which withdraw their reimbursement because they found over time it's pretty efficient. Michigan lets you do it at a lot of places, doctors' offices, hospitals, skilled nursing facilities. That's important. In Pennsylvania, they didn't really cover SNFs. And so that was a problem if you wanted to do telehealth with the aging population. It does not cover the home, and it does not cover schools at this time. And so you have to be cognizant of that. If you want to do some home-based telehealth, you're not going to be able to get reimbursed. And Medicaid reimbursement generally drives some of the other commercial payers, and they don't cover asynchronous in Michigan. The other good news in Michigan is you could be 5 miles away. So if you wanted to do it between a clinic and here, you could do it. If you're in the clinic and you want to round on the inpatient, you can do that. Some places say you have to be X number of miles away. They put geographic restraints. Michigan's not one of those. Remember, where the patient is drives everything. So the originating site is the term for the patient, and you're distal, you're far away. And Medicare really has rules around this. If you look at this map, these are the counties where Medicare now, not Medicaid, Medicare says. So this is why adoption in adults has been really hard, because can you imagine, and I don't know Michigan as well as you guys do, but I'm pretty sure where I'm at, Kalamazoo County, and where you're at, and where Detroit is, and where Ann Arbor is, and things like that, if you had a Medicare patient from anywhere there and you try to set up a clinic there, Medicare is not going to cover you. Now, the UP in general, but again, there are holes even in the UP where, so if it's basically, if it's shaded, it's okay for reimbursement. If it's not shaded, you don't get a dime. Luckily for Medicaid, this doesn't apply. There's been action in Congress to try and change the disparity because you have elderly patients who are not getting advantage of this, but their grandkids are, even though they live in the same town or they live on the same street. Regarding HIPAA, same rules apply, and everyone who's involved, including the technician, including the person who's setting up the video call, including medical records people on both ends, they all have to be trained and have to attest that they are HIPAA trained. The information not really floating around the internet, but I'll change that since what happened recently to all of our credit information. So who knows what's happening really, but ideally if you have a secure connection and you're complying, you're safe. I remember we had one breach and it was an accidental breach. It wasn't somebody hacking in, but we reported it promptly to the Department of Health in Pennsylvania. And that's the best you can do. But secure connections, compliant platforms, everyone adhering to telehealth is as good as it can be. Beyond that, somebody comes and sophisticatedly hacks and there's very little you can do, but they're just common sense things. Don't do telehealth if you're at a sports game with your patient. Try not to do it at Starbucks, things like that. If you're doing telehealth, the person at the other end is just as important as you are. They should know what to do with the patient. They should be trained. They should know how to place the camera, the lighting, the audio. They should troubleshoot. You should have the IT people helping you. The schedulers have to be involved because it's real easy to put in a schedule on one end. How do you know if the other person is available? You have to have both schedules up and match them. You have to have your privacy things. I've had places which go, let's have it in a conference room. I'm like, I'm not doing telehealth in a conference room because you can't assure me that somebody won't walk in. You're supposed to have it in a clinic room with a sign on the door saying, patient activity in progress, do not enter, or, please be cautious, something like that. Patients love it. Most of them do, because it cuts down their effort and time and cost, but they're worried about seeing a doctor they've never met before. And that's really an ongoing theme. But the younger generation says there's no problem. And part of it is, their familiarity with the technology, their willingness to accept. So 75% of older population won't trust a diagnosis made by telehealth, but only 25 of the younger said that they won't. So I think there's a generational shift where there's going to be much more acceptance. Not so with the providers. The providers are, as I was saying to Dr. Turner, are the most rigid bunch who don't want to change. They're like, oh, I think this is not good. I don't know anything about this technology. I think that it's not privacy protected. And but the residents are great. 70% of residents said, yep, we'll do it. So again, I think there's a generational shift here where there'll be better adoption both by patients and clinicians. So what is the evidence base? Because a lot of clinicians grab, oh, there's no evidence. Well, for behavioral health, it is robust. It's less robust when it comes to payment and revenue, less robust when it comes to pediatric data. And all the programs are so different. They use different platforms, they have different setups, they involve different groups, so it's very hard to do comparisons. And a lot of the publications used to be, oh, I did this one time with 3 patients and they got published. And so somebody goes, well, I did it twice with 6 patients and then they got published. And so now I think people are getting more discerning about the types of data out there. And they haven't been, a lot of this came out of clinical places, clinicians. And now there's actually a track for research in telehealth at the American Telemedicine Association meetings. It used to be a trade show. Come and see these devices. Oh, we want to try this out. And now it's like journal club type. We're going to look at very robust literature and we're going to award the best paper. Yes? So the question was, is there data outside of telehealth if frequency of contact with the clinician results in better outcomes. I'm in chronic condition. I don't know that part of literature. I know that when it comes to like my field in terms of autism or behavioral health, it's not so much the contact with the clinicians that matters, because the clinicians' input in some of my developmental disorders is minimal outside of the diagnostic piece and then the medication management piece. So when you're talking about diabetes and other chronic health conditions, I'm not very familiar with the regular non-telehealth literature. I think you're right. I think that the notion that increased contacts improves outcomes is more of a, we feel it's right, but the trick is designing a study around that would be very interesting. You'd have to, there are a lot of confounders related to, are we going to compare those who have less adherence and less contact naturally, or are we going to artificially set up groups to sort of compare that, or maybe have some controlled conditions? But that, you know, we take it for granted. You should be in touch with your clinician more often. It's like the new data around dental. So the dental thing, everyone said twice a year, go for your cleanings. And the latest data says, you know what? No, only for high risk, you need to go twice a year. Otherwise, once a year is plenty. And so that actually came out of UM and their dental school. So again, we're rethinking some of these. How often do you need contact to manage certain conditions? In terms of behavioral telehealth, there are two groups who are involved. You have the diagnostic groups, the psychologists, psychiatrists, and then you have the on-the-ground behavior analysts and therapists. And I won't talk much about ADHD today because we're going to talk about ASD, but really there's some good literature around parent training and telepsychiatry in ADHD, particularly coming out of Seattle. And Kathy Myers has been doing great work and published saying that kids with ADHD who are in contact, again, frequently, telehealth, do better. But again, that's ADHD. In ASD, it's a little trickier, and the reasons are several. So number one is, you know, this is just an all-encompassing. These are the numbers out there. We're supposed to screen more often because if we pick them up early, they do better. And we need more people after the screening. We need people to diagnose them. We need people to manage their conditions. And there's a scarcity of that. So Michigan has done good work in some ways in terms of passing laws which says we're going to cover by insurance, whether it's commercial or Medicaid, we're going to cover what they call an autism benefit for all kids till 21. But what they require is they want a comprehensive diagnostic, and then the diagnostic behavior. Now, another evaluation which says, okay, these many hours and everything. And it's only covering ABA. And that's one of the things in Michigan is they front-loaded it for one intervention, ABA. There's lots of interventions in ASD. But ABA is, yes, it's the most evidence-based, but that's all that's being driven now. And it gets interesting because there are only 13 centers where you have robust evaluations done according to Blue Cross Blue Shield. Now, that doesn't mean that the evaluations only occur here, but in general, if you have Blue Cross Blue Shield, which is a large insurer in Michigan, they'll only really allow you to access that benefit if one of these 13 places evaluate you. And so you can imagine people who are having to drive from other places to get here. The other thing is the blue areas, which as you can see can predominate, is a 0 or less than 2 psychiatrists per county, child psychiatrists. So you can see what's happening when you talk about availability of clinicians. There are only 10 developmental pediatricians in Michigan, all of Michigan, and 64 child neurologists. Again, but the trick is how many of them actually do ASD, how many are involved with seizure disorders, how many are in research, how many are in administration. So the numbers, and this is not just Michigan. I mean, there were only 14 in Pennsylvania. There's 0 in Wyoming. There's 1 in Nevada. I mean, it's not cool. There's a real paucity. of developmental pediatricians. At one point, there were 14 in Cincinnati, and you could combine 5 other states and not get up to 14. So it's really very place-centric. And the reason this is important is these clinicians are involved in the diagnostics and many of them in the interventions. Michigan requires you to do diagnostics a certain way to get that autism benefit. And that's what makes it a little tricky to do telehealth in Michigan, because they require this very involved process called the ADOS, or the Autism Diagnostic Observation Schedule. And we'll talk about it on the next slide. So they want an interview, which is history and exam, and then they want a scoring sheet filled out, but they also require this one test. And this test is basically a lot of interactive toys, and you sit down with the kid and you present a toy, you see what the kid does, or you have an activity. It's very interactive. So you can imagine trying to do that remotely through telehealth is not easy. There's one module, but that's 16 and up, adolescents and adults, which is mostly interviews. So there's a little interactive, but it's mostly questions. So our colleagues in Pittsburgh, out of rehab, they designed a module where they could do that module for just the interview and some interactive through a system where they would have the things on a tablet, and they'd have a little camera, and the person on the other end would be able to see it and then interact with it through a touch screen, and then they would ask the rest. They presented this data. We were all excited. It's not going on anymore because, again, some prominent people associated with it have moved on. Cindy's gone to Florida State University, and so program is not currently active, but there are some good efforts in terms of what can we do to take something that's in person and push it out to the community. My colleagues in Kansas are awesome about this, so they said, all right, why don't we just partner with the community? So you've got KUMC at the hub, and you have all these spokes out around Kansas, which has teams, community teams, psychologists, speech therapists, etc. So they would do part of the eval, and they would beam in the clinician to oversee the eval and provide the medical input. And so this is a nice network, and they've got it now not just in clinics, they've expanded this to schools. They even expanded this to do therapy and medication management. They're HRSA funded, so it'll get interesting when funding runs out and they have to bill and collect for some of these services. But they're conducting some of these, what people thought are impossible to do remotely, through proxy people as their arms and hands and eyes. Now remember, the tool was not designed for that, right? The tool is designed to be done by the person who's doing it. So when you add these other layers, you've got to be gentle in your report and say it was done this way, because when you do a validated tool, you can only speak of the validation in the way it was done. Another approach that Ron Oberleitner, who I know well, his own child has ASD, and he's a technology geek, and he partnered with Georgia Tech, and they have an app by which a family can record short clips of videos in their home. They structure them around mealtime, playtime, etc., and then they upload those to a server, and then clinicians take a look and make diagnostics. So there's good and bad about this. The good is it teaches parents to be great observers. It captures data in naturalistic environments, which has always been my beef about. You bring somebody into the clinic and you're trying to diagnose them, and are they really behaving the same way they behave at home? The limitation is it's in Arizona. They're trying to branch out. The problem is you will need to have clinicians trained on this approach, and they have to be willing to do this. There's billing implications because remember, this is store and forward now, right? This is asynchronous. Number two is it's in the home, which is generally not covered. So this is going to be interesting in terms of sustainability. But this is another example by which technology and telehealth is sort of intersecting with ASD. In terms of treatment approaches, I think we have a little more robust activities around there. And there's lots of different approaches, but I'll talk mainly about 3. Parent training, which is important in managing behaviors, direct or the applied behavior analysis approaches, and medication management. A lot of the other things, as we had talked to in a previous slide, a little tricky to do around licensure and Many of the OTs and speech people have not really trained in telehealth models to deliver some of the interventions, but they all have potential. Laurie at the Mind Institute, UC Davis, was one of the early ones in 2012, 2013, was doing a website with information for parents, but also video conferencing. And they are big fans of the ESDM, or Early Start Denver model there. She found that there was good acceptance in terms of doing the telehealth model. But again, outcome data was lacking. This was more about acceptability and feasibility. They didn't really say we compared this to others who were not getting and found they were equal. The next person who did this, Pickard, found that, again, acceptance, but then they found that they wanted to do more than acceptance, and so they started looking at parent knowledge, the fidelity of the interventions, and some of the skills. And so, as you can see, the literature is evolving from the whole, are you satisfied, is it working well, to now, let's look at outcomes. And so parent training now, there's a lot of places doing it, because a therapist does a lot of coaching online or through video conferencing. Again, these are not generally reimbursable in a traditional model. So some of these are grant and some of these are trainee organizations. So trainees are delivering it with supervision from their faculty. The applied behavior analysis always starts with, tell me what the behaviors are. And so Minnesota and other places have been doing, let's analyze a child's behavior in the home and then follow it up with training. And Scott Lindgren had a nice sort of comparative model of outcomes, looking mainly at economic outcomes, like how much does it cost, and found that if you compare telehealth, obviously, to in-home, the therapist going there, it was cheaper. And this is good news, because telehealth is applied behavior analysis, when delivered in a certain way, is extraordinarily expensive. I mean, numbers range anywhere from $50,000 to $75,000 a year per child. And so, Michigan is doing great that they're funding some of this, but, we've got to find ways to make this perhaps less cost burdensome, because families who don't qualify for the benefit, there are many who don't, depending on the type of insurance they have, whether they're covered under Michigan's law. I mean, they're out of pocket huge amounts of money. Psychiatry, they were early starts. So we talked about Kathy looking at a variety of things. She's gone more in the direction of ADHD in Seattle, but early on she started looking at ASD and would telepsychiatry work. Roxy in Cedars-Sinai had done a lot of different models, psychiatrists working with the PCP, psychiatrists taking over the care, psychiatrists doing a co-model, lots of different things. But there's not been a lot. There's not been a lot of publications on telepsychiatry. In a way, I'm happy, because nobody should assume that autism spectrum disorder is a medication-related condition. It's mostly behavioral and social and communicative. But it would be nice, because about 30 to 40% of kids with ASD actually are on medications, and quite a few of those are on multiple medications. So hopefully there'll be more literature in ASD, as there's more literature on telehealth with telepsychiatry and PTSD, anxiety, ADHD, as I said earlier. Effectiveness, there's limited data. Some people believe, and I had a paper that I once put in how telehealth is better. It was very controversial at the ATA in Tampa. I put my post as telehealth is better than in person. And then in small print, for some things, people come up and start going, what do you mean? I gave them a great example. Is in Kentucky, I would be seeing a patient, and some of my patients are a little ornery, and this kid just didn't like what I had to say. So he wanted to hit me, but he can't hit me from 100 miles away. So he's kicking the stand of the screen. And when he started screaming, I just turned the volume down. So it was real good for me. So there are some cases in which, telehealth is beneficial, but not really for child outcomes. Michigan is really doing a lot of things. So out of they have the psychiatrists doing something called the MC3 program, where they do phone and teleconsultations over psychiatry issues. but they only do it in 18 pre-designated counties in collaboration with the community mental health coordinators and social workers. And then MSU, as Dr. English had pointed out, is working with partners, including me and DeVos and Pine Rest, about initiating telehealth in the Upper Peninsula, particularly around ASD. But the tricks are, who are your partners? Are you thinking of everyone? Don't just think of the physicians, think of everyone involved, everyone on every end. Where are you going to do it? Who are you serving? What do you need? What's your process? What's your training? Your billing, understanding? It takes a while to build these, as we're finding out, but as long as you know what you need to do and who you need to engage, it's better than just running straight into it, because invariably you'll fail. And so I think that the things we need to do in Michigan is build our network, really partner. And Marcia Franks is here from the Epilepsy Project, and she can attest to the partners are important and the network is important. We've got to improve access. We've got to be more efficient. We got to sustain. You can't just do something and the grant money runs out and then you fold it. I've seen that around the country, and it's no fun for the patients. And we've got to get creative around different types of interventions, what we can deliver, and conduct the research, because without that, you can't talk about, evidence base. If you're just doing something and you're not collecting data, it's no good. So my hope is, after blowing through all this, that I can answer questions, and I'll be happy to leave the slides. There's lots of policies and guidelines and things out there from a variety of organizations. I've put my references in there from a variety of articles. Oh, look, there's one from me. And just, my hope is to continue, especially the trainees in the room. There will come a day very shortly where part of your job description is going to be telehealth, because it's not about traditional in a room with the patient anymore. It's either going to be mHealth, and you're supposed to provide input. There's going to be remote monitoring, and you'll have this dashboard of data from their workplace in their home, and you're going to have to figure out how to manage this. So knowing about it, understanding its limitations, but attempting it, not shutting your eyes to it. And the good news is that you guys are willing. So, here's to a better future. Thank you.
Thank you very much. I'll just comment that in a state the size of Michigan, we have this opportunity to improve child health statewide. We will never accomplish that unless we figure out how to use telehealth to do it. The logistics are impossible otherwise. We've been in the Upper Peninsula several times, including recently. The need is great. We'll never have enough primary care physicians in all the places we need them, much less access to specialists, unless we figure out how to do this. So, thank you. Thanks very much. We have time for a couple of questions. Neil has to hit the road for Kalamazoo in a few minutes because he's on a PhD advisory committee that's the candidate is presenting this morning. So, questions, comments? Dr. Turner.
Yeah, thanks, Neil. Great presentation. So helpful. So glad to have you here and help us. I just want to make a comment about how long and how hard it is to get this rolling. I was cleaning out old file folders in my office in Michigan Services, and I came across some files on telehealth. And some of them were from like 2004, with a map of the UP and where telehealth is happening and where it's not happening, where is it? And we have been working on this, and kind of people get, just like you said, you get a grant and somebody sets it up and there's a champion and it's getting going, and then or you get, one of our telehealth providers in the UP is Mike Nidifer, a general pediatrician who can't manage a lot of kids with chronic health conditions. I don't think he's awarded in the UP, but he's essentially a developmental pediatrician. And he's doing telemedicine regularly, particularly regarding ADHD. And his flow is about 4 to 6 kids a month. And that's the number the most that's happening. So I don't really have a question for you. I think one of these days we're going to hit a tipping point and it's going to take off. And how do we get there? Because for the families, it is such a bonus.
Yeah, I think the clinicians need to be more open-minded about it, and the systems need to be open-minded. Very often telehealth is considered an added burden on operations because you got to get the equipment, you got to train people, but they don't understand that when it's done right, and I've been doing this now for 10 years, when it's done right, it's as efficient. I would not take more time in my telehealth encounters than I would in my in-person. Initially, it might take more time to get things set up and people have to, but once it's rolling, and patients don't want to give it up. When I was doing it in Kentucky, and I was doing it twice a week for 4 hours each time, large number of patients, I had one patient refuse to do it, one out of like 4 years of twice a week, 4 patients a day. And her reasoning was incredible. I said, this is 6 miles from your home. You live 2.5 hours away from me. Why? And she goes, the shopping's better in Lexington. That's it. That was the only reason, not because she didn't like telehealth. That's why she would reject that, because she didn't want to go to hazard to do it, even though it was right there. But they love it, and we should really think about our patients, because if we don't, somebody else is going to. Once they lower the state barriers, a great example is the Cleveland Clinic is now in Virginia, doing telehealth, doing stuff around cardiac disease. Nothing is to stop. This is no longer a Michigan, where's our boundaries, which one is UM, which one is MSU. I'd love to see how everyone would react if the Mayo Clinic was right here in Lansing through telehealth, right? I mean, this is where, for survival of systems, this is going to be important, because those barriers are going. Those barriers are going, and Cleveland and Mayo and Kaiser are already on top of it. They've already started to make moves and have different things. Mayo has been partnering with Walgreens. They've been people that it's getting very interesting. You're going to see, a pharmacy thing with a kiosk where a doctor from anywhere in the US can come in. And then I defy you to say, no, you've got to drive 40 miles to come see me. So we got to get on this, and it's incumbent on us. The patients want it. They just don't have the control to launch it. We do.
Yeah, two comments. One is, up on the Upper Peninsula, we heard very sad stories about families that had moved from the UP somewhere else because of a failure to get access to the care that their kids needed. They finally tried and gave up and moved somewhere. So sad, to Jane's point. We've known this is a problem for many years. And the last point I would make is that the telemedicine experience, and Neil, you can comment on this, went through pediatrics. The American Academy of Pediatrics has been very clear that they expect telemedicine to be related to ongoing physician-patient relationships. This is not support for the person that you can go Google right now who will look at your throat from the camera on your smartphone and tell you whether or not you have strep throat. This is not that kind of medicine. This teleconsultation is connecting the docs in practice who need help and need expertise and need referral to experts to help them manage some difficult patients. It's got to be connected to that, and ideally it's connected to the medical home. This is correct. This should not weaken, this should strengthen the medical home over time.
And part of the reason was they have been doc in the boxes, which you can just touch the app and you'll get somebody in less than 3 minutes, and you put in your credit card information, and after that's accepted, you can see the person, and you open your mouth or they look at your rash, and it's $35 a pop. But that weakens the medical home, because there's no way to close the loop back to your PCP that you were put on amoxicillin or whatever, and they don't have your medical record to know if you have allergies to amoxicillin. So Dr. English is right. In the context of medical, which the AAP recommends, I don't recommend it any other way. I'm not a big fan of on the fly, because on the fly comes with the risks of, have you trained your patients not to be communicating while they're walking through the mall? Because that sets you up for a HIPAA violation if you're not careful, if somebody else overhears and they go, I heard her talking to the doctor. It's not the patient who's going to get in trouble for those things, because you didn't detail the patient to go be in a room, close the door, and tell me. Families think that it's the same as just being on FaceTime with their family members. It's a little different when you talk to a clinician. You've got to have that privacy. Thanks again. Thank you for coming.